Hello, good afternoon. My name is Michelle Moser. I'm a clinical liaison with Revelation Pharma, and today we're going to talk about the latest research in multiple sclerosis and low-dose naltrexone. So this seminar is strictly for informational purposes only. Please seek medical advice as needed. And I will talk a little bit about compounded medications, which are not necessarily evaluated by the FDA. So let's talk a little bit about what the latest research about MS says. How does the gut biome play a role in autoimmune diagnoses? What is epigenetics and how does that influence autoimmune diseases? What kind of testing can be done, as well as what medications can be used to decrease symptoms and improve quality of life? Multiple sclerosis is one of the most common autoimmune neurodegenerative diseases in nearly 2.5, I've even seen up to 2.8 million people worldwide, and anywhere from 1 to 1.5 million people in the US alone are affected. 80% of those diagnoses are women. It does affect women more so than men. And it's really thought that multiple sclerosis over time decreases what's going on with the myelin sheath. So usually it breaks down, exposes nerve, and therefore messages are not sent appropriately or possibly not even at all. It's very common in the 47th latitude around the world. And like I said, it happens more in women than in men. Men do get MS, but not to the rate as women do. What we know is that all disease is centered in inflammation. Inflammation then reduces transmission of information between neurons, especially dealing with multiple sclerosis, which means we really need to calm the microglia around the body. But there's so much microglia in the brain that we really need to decrease that inflammation. Usually we're looking for plaques or centers of inflammation in the brain to do a diagnosis of multiple sclerosis. There is a vascular component to this, usually leading to damage of the blood-brain barrier, which can allow more immune cells to leak into the brain space. There's a correlation between the gut microbiome. There can also be a vitamin D deficiency, which happens more often than not. Sometimes there's even an underlying viral infection, which may be undiagnosed. Gluten intake can influence what's happening with MS, and smoking can have a direct correlation as well. So we all know what genetics are. So genetics are the DNA that we're born with, but over time, whether it's environmental issues, hormonal changes, or nutrient factors, we can see changes in our genetic makeup. Therefore, our epigenetics, what is actually happening with our genetic code, can change over time. So the DNA that you're born with isn't necessarily the exact same copy of the DNA that you pass away from. So the genetic mutations can also therefore change neurological diseases and allow for neurological diseases to pop up. And how we respond to those and also respond to those treatments is very much dependent on genetics and epigenetics. There's evidence that autoimmune diseases are caused by an interplay between environmental influences leading to genetic code changes that both instigate the disease process and determine the responsiveness of any given therapy. So the bottom line is your genetics are not necessarily your destiny. You can make changes. Even after a diagnosis, you can still make changes. We can look at genes. 3x4 genetics is just one example of a genetic type test. So with that, we can make better decisions as to what pharmacotherapy will work in an individual versus not. With 3x4 genetics, there's 36 core insights that determine inflammation, brain health, gut health, hormone health, really what's happening with metabolic processes, and really so much more. There's even information on how well we respond to different types of exercise, for example, or metabolize salt. There's just so many different areas that when we have that information, we can really use that to our advantage. So the gut microbiome link, we're seeing more and more information that's popping up about whatever's happening in our gut can directly affect the rest of our body, especially our brain. I've even heard the term that our gut really is our second brain because about 70 to 80% of our immune system actually resides in our gut. Our gut makes medium chain fatty acids, which are food sources for our brain as well. And our diet has to be processed and absorbed to get the right building blocks for proper health. So, what you're putting in has to be changed. So, if we don't have the right bacterium, the right makeup, and even micronutrients to help get those building blocks stabilized or even allow for mitochondria to work more efficiently, that all begins in the gut. Maybe we have food sensitivities that we're really not aware of, or intolerances, or even nutritional deficiencies. Perhaps our diet is not such that we eat enough vegetable. Maybe we don't eat the rainbow. Maybe we don't have enough good fats in our diet or even good proteins. Perhaps it is truly a SAD diet, a standard American diet that doesn't allow for us to have the proper nutrition to have a good, healthy body. Exposure to pathogens can be single exposures, it can be multiple exposures. It can happen very early in life and carry forward to the later years as well. And that's really important, especially if there's mold, and all of the other environmental toxins that we either breathe in or take in orally. Perhaps it's even on our food or in the clothing that we wear. All of those exposures can have a significant impact. Oh my gosh, stress. Should we really need to talk about stress? I mean, we all know that stress is it's got to be the number one factor that causes so many different disruptions throughout the entire body, especially if we're talking about disease states. Cortisol goes up, inflammation goes up. We just don't adapt appropriately. That also leads to a lack of sleep, because if you don't sleep well, you don't feel well. And if you're not getting good enough sleep, not just last night, but really day in and day out, every day of the month, that can absolutely change your weight, cause additional inflammation, disrupt how hormones work in the body. It can even change your immune system. Hormone balance is very critical, not just early on, but really throughout life. We know that hormones play a very integral part of our immune system. And if we have low amounts of hormone, our immune system is impacted. We also know that low hormone levels can actually be an invitation for cancers to grow. So that has a dramatic link on overall health as well. A wide variety of medications can cause micronutrient deficiencies. We know that there's a lot of medications that cause a variety of B vitamins to waste out of the body. Magnesium, for example, can waste out of the body. And even just the sodium-potassium balance can be affected by a wide variety of medications. Environmental toxins, whether it's literally just the air that we're breathing or any type of biphosphonates on paper. It could even be the use of plastics, because plastics do look like xenoestrogens in the body. So especially if they're warm, like if you get takeout food, is it coming in a styrofoam container? All of those environmental toxins can have an impact over time, not just on autoimmune disease, but just overall health. And of course, gut dysbiosis. We don't have the right balance of the good guys and too many of the bad guys, or even other pathogens that are in there that are causing just changes in how we metabolize our foods or producing byproducts that are then being absorbed when they shouldn't be. If we don't have enough akkermansia, for example, we're not able to really control blood glucose very well. If we don't ferment appropriately, how is that affecting our mood? How is that affecting our absorption of good nutrients? The lining of the gut is only one cell thick. So if that layer is so fragile, if we have a lot of inflammation, then some of the normal metabolites can actually leak through those junctions and go to places in the body where they're not necessarily intended. So it's not just necessarily the bad guys always being there. Sometimes it's just normal processes that with through leaky gut can actually have an impact elsewhere in the body. Microbiome labs is again just one example of how we can take a look at what's growing. This is a complete DNA sequencing of everything that's going on. Usually you get about a 20+ page report, and it breaks it down into species and families so that people can actually make informed decisions about how to carry forward. Gluten. Okay, we've heard a lot about gluten over the last, especially the last 10, 15 years. And really, this goes back to, sometimes in the late 30s and in the 40s, there were some scientists that were really trying hard to eradicate world hunger and being able to provide nutritious food worldwide. And that's a very noble concept. However, the testing really wasn't done as to how many genetic changes were being done to wheat harvesting and exactly what did that mean. So over time, gluten, which is primarily found in a wide variety of grains, barley, rye, mainly wheat, the protein structures have changed and they're much smaller yield of protein in a wheat chaff than what we used to have. And with that, we have found that through wonderful books like Grain Brain and so many others, that Wheat Belly, for example, gluten acts like a thyroid molecule. But when people have sensitivities to gluten, not just even um, a full-on intolerance or a celiac diagnosis, they don't even have to have that. Just a sensitivity. Sometimes that can mimic multiple sclerosis. It can even on MRI, it can look like a plaque, which can lead to misdiagnoses. So Dr. David Perlmutter is an internationally recognized integrative neurologist. He wrote the book Grain Brain. And whenever he has patients referred to him, he always says a gluten sensitivity test. Pretty easy to do. Quick test, results come back fairly quickly. And what he has found that if he removes gluten from someone's diet, he can go back and look at MRI, and sometimes those plaques are no longer there, where they may not have really had MS to begin with. What he also links is that those brain changes are probably produced by gluten sensitivity because there's a development of a leaky blood-brain barrier, just like what's happening in the gut. Dr. Fasano at the Harvard Medical School, he's also has a private practice. He also wrote that leaky gut can be caused a lot of times by gluten intake. That leaky gut allows for bacteria, yeast, pathogens, toxins, and even partially digested foods to activate the immune response because they're not supposed to be there, right? So the immune system kind of sweeps in and activates and tries to scoop it up and clean it up. Well, that all can lead to inflammation and also autoreactivity because you're actually reacting to yourself. He links these changes to a leaky blood-brain barrier that develops when people with gluten sensitivity still have gluten in their diet. These are the references for that. So perhaps one of the first things we might want to do with MS is take gluten out of the diet and see what happens. Maybe that alone will improve symptoms such that we may not need to carry any further, or we can actually look at other medications. So usually what happens is that someone may be prescribed steroids to reduce inflammation or biologics. They tend to target blood immune B and T cells, but not necessarily targeting those B and T cells in the brain. George Washington University is working on a new drug, by the way. And we've had immunosuppressants around for decades. Good, probably, what at this point, probably 40, 50 years. Drugs like cyclophosphamide, azathioprine, methotrexate, those are very, very common. And they usually work by suppressing interleukin 12, which is a pro-inflammatory cytokine, and the Th1 type responses, enhancing the Th2 and Th3 responses, which also reduce cytokines interleukin 4 and 10. But we also see a suppression of eosinophils in the peripheral blood. Of course, there's anti-inflammatories too. Those are usually classified as non-steroidal anti-inflammatories, and that reduces inflammation throughout the body, both peripherally and centrally, through a variety of pathways, depending on the type of anti-inflammatory that it is. And then we also have low-dose naltrexone. We can get into that as well. But when we look, back 10, 11 years, Norway as a country found that treating MS patients with LDN reduced symptoms, improved quality of life, and reduced the number of prescriptions written for opiates. Because a lot of times these vasomotor skills in a wide variety of symptoms are based in pain, which leads to chronic pain due to the inflammatory responses and the demyelination of the nerves. So you have irregular or inappropriate signaling happening down the neuron, and perhaps that is triggering a wide variety of types of pain through afferent and efferent pathways. Patients also, in this study done in Norway, they reported very few side effects. The median age was about 52. 74% of those patients were female. The average daily dose was about 3.7 milligrams. So what that means is that as they individualized the doses, some got up to 4.5, but more were down around the 3 milligram dose. Some were even a little bit lower. It just really depended on that individual and their response to medications. So what happened there is, as they were given doses and their doses were increased, if upon that next escalation of dose, they had a variety of symptoms or they didn't feel as good as they did before, they would literally drop the dose back down. 20% of all doctors and 71% of the general medicine practitioners registered in Norway in 2014 prescribed LDN at least once. That's a lot of providers. What they also found is that over time, so since 2014, a lot of these patients have continued on LDN, which has further reduced the number of opiate prescriptions written and have improved quality of life for these individuals. And here is the citation. What we know about LDN is that, so naltrexone is a drug entity that was approved by the FDA in 1964. So that is now 60 years. Over time, we have learned its mechanism of action, that it binds to toll-like receptor 4. It activates those innate immune cells. It blocks the inflammatory lipopolysaccharides, and that prevents the LPS from producing inflammation. So those are primarily those cytokines of interleukin 10, 6, 10, and 12. We've heard a lot about interleukin 6, mainly because of recent COVID infection, and we knew that that inflammation was primarily spurred by interleukin 6. LDN also helps to tighten the junctions in the gut lining, so the gap between the cells actually becomes tighter, because of course if it's loose, then other things can pass through. Helps tighten that up. It helps to modulate hormones, and that information comes from, it helps to normalize thyroid function. It helps to also help the cells take in estrogen, testosterone, progesterone, DHEA, pregnenolone in a much more efficient pathway. It reduces irritation by blocking toll-like receptor 9. So toll-like receptor 9 is on the cell surface, and that's where some of the kind of tingly, pins and needles, but also the itching comes from, and that can happen on the skin surface, but also elsewhere in the body. It blocks the opiate growth factor receptors, which can reduce tumor growth. And as I said earlier, it shifts Th1 to Th2 and Th3, which reduces allergic type responses. So low-dose naltrexone is compounded. So it is commercially available in a 50 milligram tablet. It's packed in lactose and colorants. A lot of people with autoimmune disease are very sensitive to dose. They're also sensitive to a wide variety of binders and fillers, as well as colorants. So a lot of times they will say, I'm really, really sensitive to medications. That's okay, because with low-dose naltrexone, we're going to start low, we're going to go slowly, and we're going to compound that into a dosage form that is appropriate for that patient's lifestyle, which usually means capsules, sometimes liquids. Scored tablets can be used as well. Transdermal creams or gels, so that's literally pushing the drug all the way through all the layers of the skin, delivering naltrexone to the capillary beds, which are then delivered systemically throughout the entire body. And we can also use naltrexone in a topical form to just keep it on the first few layers of the skin to actually work on those TLR9 receptors, decrease irritation and itching as well. LDN can be combined with most therapies. It's low dose, low side effect, low drug interaction, therefore low risk, and tends to be relatively low cost. Most providers say, why not try LDN? What have you got to lose? In most cases, it's really about what you've got to gain. So Penn State Hershey Medical Center conducted a 10-year retrospective study. So from about, I believe like 2006 to 2016, they looked at a wide variety of patients and they followed them over a period of time. And then they went back and looked at chart notes to really see what was happening. And this was a retrospective study specifically on RRMS, which is the relapsing remitting patients. Now, they were all diagnosed with MS prior to starting the study, and the patients were divided into two groups. So some of them were already on Copaxone, which is a biologic that was one of the first biologics ever produced to help with MS. And those patients were put into one category. And then another group of patients who were diagnosed with MS who were not on that kind of therapy were given LDN all by itself. So 23 patients were on LDN alone, 31 patients were on Copaxone and LDN. In this study, they noted that the LDN dose was usually between 3 and 4 milligrams taken once a day. So on the LDN only arm of the study, one patient reported multiple flares over the study period, over that 10-year period, whereas the Copaxone plus LDN arm, there were 6 patients that had multiple flares over the study period. What this study concluded in its writing is that they found that LDN was safe. It worked as a single therapy or an adjunct therapy to reduce symptoms, improve quality of life, and did not result in an exacerbation of disease symptoms. So again, it's kind of like, it's low dose, low risk. Why not give it a shot? It's very important to set up the expectations of how this medication is going to work. So some find realization or reduction of their daily life skills and symptoms. Sometimes those benefits happen fairly quickly. So they might gradually see a reduction of symptoms, but others may see a reduction of symptoms over the next 18 months. And so it might take a long period of time to respond. And for a lot of people, they don't have the patience for that unless they are hearing it up front that it's going to take a period of time. Doses are usually started low and slowly increased over periods of time up to anywhere from 3 to 4.5 to 6 milligrams per day. So that doesn't mean we're changing those intervals by 1.5 milligram each time. Sometimes we're starting even at 0.1 milligram, 0.25 milligram, or even 0.5 milligram. So there could be anywhere from 9 to perhaps 18 to 20 dosage changes for us to fully understand how that patient is going to respond. Now, if someone is using hormone therapy to balance hormones and they're using it and they want to use it along with LDN, that's not a problem. Sometimes they can be combined in the same capsule in the same dosage form, or they can just be added with that current therapy. We're also seeing high doses of biotin being used in MS patients. And again, that can be combined with LDN. There aren't any drug interactions there at all. But setting up that expectation at the start to ensure patient compliance is very important. And that was shown to be very evident in the Penn State study as well. And I believe even in Norway, because they let them know that, it's going to take a little bit of time. What patients reported were vivid dreams, some stomach upset, and even some headaches. And those were the three most common reported side effects. Now, those usually diminished over time, or they were resolved by lowering the dose of low dose naltrexone or simply moving the dose to a different time of day. Most people were dosed at bedtime, but some people were moved to a morning dose or just earlier in the evening to alleviate any side effects. I wanted to list these research studies separately. I find that these readings were very, very helpful and very informative. It's very interesting how we are looking at autoimmune disease, how it tends to be centered in the gut, how we're not really seeing diagnoses until someone's in their late 30s, 40s, 50s, beyond, which means it's not necessarily a genetic issues as much as it could be an epigenetic or how our genes are changing and evolving, even within that individual. But certainly there's a lot of testing that we can do to ensure that we're going to enable that patient to feel their best day in, day out, year after year. The LDN book, Volume 1, edited by Linda Elsegood. Chapter 2 was written by Dr. Deanna Wyndham, which I found very, very helpful in her talking about MS and autoimmune disease and how low-dose naltrexone has been very helpful, as well as pertaining to low-dose vitamin D and a wide variety of gut issues. This is how you can contact me. This is my email, and these are the pharmacies that I'm currently associated with. I want to thank you for your time today. And if you have any questions, please feel to reach out. I'm more than happy to help you with whatever it is that I personally can. And in the meantime, be well.